Okay, yes, I am Braunz Courtney, Executive Director of the HIV Education and Prevention Project of Alameda County. Who wants to say that all the time? So we call it HEPPAC for short. If you're in this business, I'm sure you guys use acronym talk all the time, and HEPPAC is one of my favorite acronyms. I've been with the organization about 15 years, started off as an outreach worker, worked my way on up and through the ranks because I love this place. And the last 2 years, I became the executive director, and I am just loving it right now. Being able to grow within the agency and now be the leader of the agency and do all the creative, fun stuff I've always wanted to do is just awesome. So I'm glad that I'm able to do this presentation and looking forward to questions at the end. So let's get started. So this is about utilizing harm reduction strategies to address racial inequities, healthcare settings, impact of the non-clinical mobile medical model, right? A lot of us work in medical facilities or medical homes, and HEPPAC does non-clinical settings, right? And so this is what we call street outreach or street health, street medicine, things of that sort. And so HEPPAC is a Black-owned and Black-led organization, harm reduction, and we're a standalone 501c3, which means that we're not under the wing of a larger FQHC or a hospital. We are a standalone. We own our own building because the forefathers and foremothers before us who was able to secure property in this very, very expensive place called the Bay Area allowed us to get a capital gains grant that allowed us to purchase a building at an extremely low rate. And that allowed us to own the building that we live in, because a lot of times our buildings were getting burnt down or our leases were not getting renewed because we were a harm reduction agency that did syringe exchange. So there was a lot of stigma around that kind of service. But guess what? We have no landlord, so we can do whatever we want to do in our building, and we are state and locally authorized. So today, do some welcomes, do some poll questions, talk about harm reduction, why harm reduction is relevant and why it is impactful and effective in communities of color. Talk about the mindset around harm reduction and how we combat people with other mindsets as well as allow them in, right? Because not all of us are going to agree about some of these harm reduction strategies, but we all should be aware of what they are so that we can properly refer our participants, because it's not even about us as providers, it's about our participants and providing them with options, right? Getting into options, then we're going to talk about strategies. So the strategies of how we deliver the service, strategies how we deal with participants, and how we deal with the NIMBYs, right? The not in my backyard people, the people who are like, I don't like that harm reduction, it's enabling. Hey, strategies on how to do all of that. So this is a two-way street. I am going to probably do the majority of talking, but I love questions, and I really would appreciate folks to ask me stuff towards the end. So let's get it going. So, you know, I love a good poll question, right? And as you will see, this poll question is very subjective. Let me see, because I got a lot of stuff going on here. Promoting safer use of drugs encourages drug use. Is this true or is this false? I will say it again. Promoting safer use of drugs encourages drug use. Let's see, kind of already seeing most of you. Okay. How long do you usually give, Duran, for the poll question to be answered? A couple seconds, 15?
Yes, that is good because it's like 100% have already answered. So you're good to go.
Okay, and poll, correct, right? Promoting safer drug use does not encourage drug use in general. So that's awesome, right? I'm sure a lot of us get it. And so I'm glad to see that. A lot of times in this field, and I, talk to a lot of different people. Sometimes I have my HEPPAC, harm reduction saves lives. Sterile syringes saves lives, right? I'm in Safeway, and we start talking about just drug use, and some people don't agree, right? They think that harm reduction and giving people access to sterile equipment to use their drugs is encouraging drug use. And so then while I'm sitting there trying to get my avocados and tomatoes and ranch and whatever for my salad or whatever, I'm sitting there having open dialogue with people. And like I said, not everybody's going to agree. Not everybody is drinking the harm reduction Kool-Aid, but it's a teachable moment. So, because some folks have been born and bred and brought up into the abstinence-based model of their life, and that works for them, and that's fine. However, there's this thing called harm reduction. So great to see that. Let's see here. Oh, sorry. Harm reduction, quick and dirty. Harm reduction embraces all possible responses to risk behavior. It spans a total abstinence to continued drug use. It supports people at any area of the spectrum. So this is how I talk with people who are very forward thinking about abstinence. That abstinence is on a spectrum with harm reduction, right? Harm reduction is the spectrum. And at one end of this spectrum, we have chaotic drug use. On the other end of the spectrum, we have abstinence, but it's on the spectrum. And a lot of folks who are abstinence forward thinking never knew this. For some people, abstaining from drugs completely is their harm reduction method. And so at places like HEPPAC, we encourage people wherever they're at within their use to support them in getting there. We're really just navigators. A lot of you know this. We are not driving. Our participants are driving. We are the Siri to say, hey, where are you trying to go, participant? Do you want to stop your drug use? Do you want to change how you do your drug use? You want to go from injecting to smoking? Do you want to go from something to something else? There are going to be people who are probably, and I know to this day, going to use drugs until their last days. And it's about making sure that they have all the equitable services to do that as healthy as possible, because people who use drugs deserve housing, they deserve equitable health care, they deserve to be happy and live a good quality of life. Let's see here. Harm reduction, everyday life. So when we talk about harm reduction, a lot of times we assume, right? And harm reduction is kind of based out of drugs and drug use. But harm reduction goes across the spectrum of just life. Just think of everything harm reduction you did just to get to where you're at this morning. So it's about being safer within the behavior without stopping the behavior. So some of you had to drive to work today. Harm reduction would be something simple as putting on your seatbelt. Like, I had to go to work, I could have went and not put my seatbelt on, but I did that anyway because I wanted to be as safe as possible, because people drive crazy. So everyday life could be like, you know, unprotected sex, tobacco use. I have a parent who used to smoke a pack a day. And I was like, let's try just smoking half a pack a day, right? Rewarding small incremental steps. And so from this parent who went from smoking a pack a day to only smoking like, you know, half a pack a day, that is something great. You're not stopping smoking, you're just lowering your tobacco intake. Gambling. We know a lot of people who have gambling addiction. Some people who will gamble away the mortgage and the car note, all that stuff. Some people might still continue to gamble, but they budget it like everything else. Like, hey, I got $500 for gas this month. I might have $500 for the roulette table this month. Same thing with confronting drama. There's been a lot of road rage going on. And I know back in the day, I'd get upset. I done seen people pull their cars over, fisticuff, get into it. Nowadays, it's like, you know what? You flip me off, just go about your way. I'm not even looking at your way, because people are literally getting shot down, and you know, and bad things are happening if you're getting into drama with road rage. Same thing if you've got some beef in the store or something, if somebody says something to you, just, life is too short. I ain't got time for the drama. It's just like, hey, go about your life, go about your business. So when we talk about harm reduction, we're talking about it in every avenue of how we live, right? Preventing the harm, but not necessarily stopping these behaviors. Substance use and crossing the line, right? So drugs is a substance recognized in an official pharmacopoeia or formulary, a substance intended for use in the diagnosis, cure, mitigation, treatment, or prevention of a disease, and a substance other than food intended to affect the structure, function of the body, right? And so we think about why people use drugs. People use drugs most likely, correct me if I'm wrong, to not be in physical, emotional, or mental pain. Also, recreational. Some people just want to have a little buzz when they're going out and enjoying their personal life with their friends. And it's funny that, you know, they're always talking about like the safer consumption spaces, and we're fighting to get safer consumption spaces, safer injection sites, all that, right? If you ever think about it, bars are safer consumption spaces. This is where I can go, get alcohol, be in a space with other people drinking alcohol, and kind of be safe from the elements. Now, it's how you leave that bar, right? Do you call an Uber? Do you have a friend come pick you up? Do you notice that I only had a sip? I think I'm cool to drive, so therefore I don't feel like I'm putting myself at risk. So bars are safer consumption spaces. But people use drugs for a variety of different reasons. And it's not our job to judge why people use drugs. It is our job to say, hey, how is your drug use doing? What can we do to assist you in having a healthier quality of life while you're continuing to use drugs? Or how can we help you get to the avenue of where you're trying to go? Do you want to stop using drugs? Do you want to use drugs a different way? Do you want to have a different relationship with your drugs? What is it that you want so that we can support you in that? Poll question number 2. What is the best drug? I always love the poll questions that don't have a right or a wrong answer because everybody's got a different perspective and a different experience with all these different drugs here. And so I would love to see what y'all think are the best drug out of these 4 that I chose. I always like seeing the, as it's moving, who's voting on what. Okay. All right, I think we're there. I think coffee seems to be the winner. Woo, let me tell you about that drug. I love me some coffee, right? Coffee is awesome. Let's see here. I think I can stop sharing, correct? Let's stop sharing. Poll question 3. Can you guys see your results? Give me a thumbs up if you can. Okay. All right. So yeah, coffee. Love that coffee. That's my morning drug. Sometimes I can't even complete a sentence without my coffee early in the morning. If it's real early, I'm like, look, don't talk to me. Give me a good 15 minutes before I can like get my coffee in, kind of get my morning going so that I get my mojo. And then that's when I start talking fast. And folks are like, oh, too much coffee. Slow down, Braunz. But yes, coffee is definitely one of those wonderful drugs. Let's see here. I'm having a problem with moving to the next slide, Duran. Let's see. Technical difficulties, one moment.
I can see your mouse moving.
Got you. Poll question, here we go. Hopefully everybody can see this. What is the worst drug when it comes to nicotine, crack, meth, or heroin? I see some going neck and neck. Okay, I think we're about there. So the worst drug identified by every 33 persons on this line seems to be methamphetamine. Yeah, meth is pretty raw. I've known some personal friends who are addicted to meth, some more functioning than others, and meth has not been anything positive around it that I've heard. Other than I have heard that it, for some people with sex addiction, and this is from my own personal experiences of people who I know, it is really utilized with folks who like to have a lot of sex, and some folks who I know who've had sex addictions, that meth is their primary drug of choice. But we know that meth does a lot of damage to the body. And so, yeah, I can agree with some of you that meth is good, but at the same time, a lot of these nicotine, you can buy that over the counter, right? It's killing so many folks, lung cancer, crack cocaine, which was, tore down communities for decades, specifically the Black community nationwide, and then heroin, yeah. So thank you guys for giving your input on these specific drugs.
And Braunz, you had a couple in chat as well. Somebody chimed in around alcohol, and then there's also no worse drug to me. So not one or the other is the worst. And then
Mhm.
somebody also agreed that alcohol was a worse drug.
Mhm.
So folks are chatting in their responses as well.
Right. I can't see the chat too much, but I can
I
agree
got
with
you.
that. One of that being is these are over-the-counter items. These are what, and as we're getting into the next conversation, these are illicit drugs. These are allowable, right? You can go to a bar, you can get alcohol. You can go to a liquor store, you can get cigarettes. They've got cigarettes and vending machines. And so I grew up in a family of people who were alcoholics and who smoked a lot of cigarettes. I have grandparents who have passed away due to cancer, lung cancer, had emphysema. It's interesting. We actually get some funding. It's called TTSF, Tobacco Tax Settlement money. And so, you know, the tobacco industry has to give money out because their product kills people. It is known, right? And you could have something that kills people and is dangerous. It's labeled right there on the box. And that doesn't mean that people aren't still going to utilize it, right? And it's funny, I grew up in, you know, the 80s and they used to have the Marlboro Man and the cool guy. These are commercials. And I remember smoking candy cigarettes, right? Does anybody remember candy cigarettes? Like, oh, I just love candy cigarettes, watching my parents smoke. And we used to actually like roll them back up, put more powder in them and just poof. We just thought it was so cool to like be smoking candy cigarettes. And now I look at that like, you are encouraging young people to smoke? Are you kidding me? I can't, right? But growing up on candy cigarettes, that was just so interesting looking back at that now. They could never do that. Oh my gosh, that would now in this day, that couldn't happen. It would be a whirlwind. But let's get into the conversation around illicit drugs versus illicit drugs. So illicit drugs are prescribed by a physician, includes over-the-counter medicine that is to be used as directed by the packaging. Examples, alcohol, caffeine, or nicotine. Then you have illicit drugs, are substances that either stimulate or inhibit, the central nervous system or cause hallucinogenic effects, has been prohibited globally. Examples, stimulants, cocaine, amphetamines, heroin, sedatives, hallucinogens, marijuana, LSD. Marijuana just recently became illicit drugs. But I remember back in the day, you know, a lot of folks did time for having weed on them. And now you can go into a coffee shop, get you a latte, get you an eighth of that top shelf purple, granddaddy, all that good stuff. So it's just interesting how times have changed, right? And so who's to say in the next 10 years that some of these illicit drugs that are listed now will be licit? Who knows? Maybe cocaine will be legal, you know? So just let's pay attention to that. And I am going to the next slide. Here we go. When does it cross the line? So this is subjective, right? Because some folks assume normal recreation and social fun with drugs is okay. But then you have folks who have their chaotic stage of use and they assume these folks are morally weak, right? And so getting down to the nitty gritty on like why a person uses this drug. Some people are dealing with trauma. Some people are dealing with the physical pain. And sometimes that can turn into chaotic stage of use. The difference for me is when a drug consumes the majority of your life, where you are literally waking up and your first thing is, I have to do whatever I need to do to get this drug in my body, whether that means sell my body, sell all my shit, not go to work. Everything's just focused around this chaotic stage of use. At the syringe service program, the needle exchange in the non-clinical setting, sometimes we see people in their chaotic stage of use. However, the fact that someone may come and they're like what we would call tweaking or like amped up, and you can see that like they're on a drug that has got their behavior in a chaotic, visually chaotic stage. The fact that they came to a syringe exchange shows that they are taking care of themselves. Even in their most chaotic stage of use, you have come here to get something that you need to keep yourself safer. Whether it was, I just need some coffee, I want some condoms, I want to get some sterile syringes, safer smoking kit, I need to get tested. I just need to be around people because I'm freaking out because my drugs has got me tripping and I just want to be around somebody. I might need access to Narcan. I might feel like I'm about to OD or whatever the case. So awarding small incremental steps. When people come to us, they're not always going to be nice. They're not always going to be friendly. Sometimes we're like, hey, how's your day? What do you mean, how's my day? My day freaking sucks. Well, and they start going on. It's just like, whoa, well, let me check in with you. What can we do to help you at this moment? You might just need some water. You might just be dehydrated. So something as simple as just one, acknowledging that people are not always going to say hi, hello, and be grateful to see you, right? Folks are coming to see you and they're already feeling some kind of way. There's a power dynamic, right? That you already are the provider, that have something that people want. And some people have internalized stigma that I have to go to you and ask you for something. Basic need stuff. I need to ask you for a hygiene kit. I need to ask you for a safer smoking kit. So I'm already feeling some kind of way about myself. But what we do as providers is just encourage people. Thank you for coming. Who knows what it took for you to get here? Who knows what it took for you to get up this morning? Thank you so much for just being here. You don't have to, thank me. I don't need you to, be super nice to me. I just need to be respectful of the space and let us know how we can further assist you. Harm reduction mindset, that safety is more important than abstinence. As we've been having this conversation, someone being safe is the top priority, right? In harm reduction. What we're doing is disease prevention. We're preventing people from dying, and we're not necessarily telling them to stop using drugs. And sometimes that's hard to have conversations with people who are abstinence-based forward thinking. They're like, you are encouraging people to use drugs by giving them access to sterile syringes and not telling them that they need to stop. No, what we're doing is giving people the option to be as safe until they're ready to stop or change the way that they interact with the drug. And like, I can go back and forth with like very close people who I love when it, the conversation is about enabling versus supporting. And maybe some of you here have had those conversations with your colleagues, with your parents, with your loved ones. It's interesting. Sometimes people are like, what you do is legal? And I'm just like, and then I have to talk about harm reduction, how we're state authorized, and how syringe access services have been proven with data to decrease HIV, Hep C infection, disease prevention, and actually decrease people dying, right? People know themselves best. So it's about giving them the options. Hey, what did you come here for today? You want to get tested, you want to get sterile syringes. Let's talk about what that looks like for you, right? How is drug use going for you? Most people are used to having the punitive conversations around their drug use, and doctors are telling them, okay, well, you just need to stop. Well, the reason you got abscess is because you shoot dope. You should just stop shooting dope. Well, maybe they don't want to stop shooting dope. So let the conversation be, how is injecting drugs going for you? You've collapsed out some of your veins. Let's talk about safer injection practices. Are you rotating your veins out? Like, how are you hitting? How are you even literally putting the needle in your arm? Are you making sure that you're sanitizing with alcohol wipes, right? Who's your dealer? Having conversations with, do you even trust your dealer? Are you getting your drugs from multiple different sources? Are you testing your drugs with fentanyl test strips? Because fentanyl is taking people out left and right. So it's like having these open dialogues around the ambivalence of drug use. What's great about your drug use? What's kind of effed up about your drug use? How can we help you in whatever goal you have around your drug use? Those are the open-ended questions, right? How, when, why do you feel like you use drugs? These are some of the open-ended questions that we want to ask people. And like it says here, people are most likely to connect with others when they feel respected. When we're talking to people who use drugs and been using drugs for a long time, you're literally talking to an expert. It's funny because I've talked to people and they're like, boy, I got veins older than you. I've been shooting dope longer than you've been on this earth. And I'm like, wow, that's expertise that you have there. And I want to hone in on that. How has the drug landscape changed from when you was injecting drugs 34 years ago, 40 years ago, to the drugs now, right? So you're an expert and you have expertise in that. And we need to hear that expertise. It was one time we have got syringes donated from the state on this special grant, and they were a syringe that I wasn't familiar with the vendor, because usually we use Easy Touch or BD, which if people don't know is like the Versace of syringes. That is like the top quality syringe. And so these were not BDs and not Easy Touches, and we were giving them out, and I've never injected, so I don't know, right? I have family who have, but I've never put a needle in my arm to know, like, on a consistent basis, if this is a good vendor or a good quality syringe. And they were like, this shit sucks, what the hell? So I heard that from more than 5 people. So I had a meeting, we pulled the syringes off the line. I had a conversation with the entity that gave it to us, and I was like, hey, this is the feedback we're getting from these free syringes. So what do you want me to do? You want me to dispose of them, or you want me to send them back to you? Because we're not going to put them on the line, because what that could tell people is we're not worthy enough to get the best quality drug using supplies. And so just imagine some of our participants who don't feel like they're worthy enough, or people are turning their nose up at them, or all those negative things that happen with our participants throughout the day. So when you come to HEPPAC, we want you to have the highest quality supplies. So you are going to get easy touch, you are going to get BD. But these are the feedbacks that we need to hear from our participants about, like, how is this product we're giving you working for you? It could be down to the kind of condoms you get. We've had people, who've given us donated condoms, and we're like, oh, great, free, right? Less stuff out of our budget. Then we give them, people like, these condoms suck. Is this what we're worth? These cheap ass condoms? And so we need to hear this feedback from our participants. So we pulled those condoms off the line. So not everything that's free that we get as providers is good, but we need to get the feedback from our participants and be like, how do you like this? Is it a good quality for you? If not, what do you like? We've had a lot of people tell us, man, this is the best condoms out here, or this is the best syringes. And that's why we now have those on our line, right? So really trust in the expertise of our participants, because they know themselves better than anybody. Check your expectations, right? Like, all of us have expectations. Some of us even have trauma related to the fields that we work in, from our parents and our family. Being a child of a person of two parents who are addicts, something I might see in a participant reminds me of my dad, who is currently still smoking crack, right? And so it might be like, ooh, I want to get this person clean, or I think they need to do this, and I think they need to do that. No, I need to check that at the door, because you're not my dad, right? And even with my own parent, being in harm reduction has made me be a little bit more empathetic and compassionate about what they're going through. But we need to check our expectations at the door. Medical, I'll just read off. We got to be careful in how we deliver information and education to clients, especially if you are triggered. Body language is a powerful form of communication. So I don't have a poker face, and that's something that I need to consistently look at, right? And so if a client comes up to me or a participant comes up to me and says something I don't like, and I'm like, ooh, they're going to see that. I don't even need to say the part. I could just curl my lip up and throw my head back, and that says something to a participant. So what I do at HEPPAC is we do a lot of mock sessions. We love to do scenarios and talk about situations that happen at the syringe exchange or in the office. And we kind of give each other feedback of what we are verbally saying to participants, and feedback on what our body language says, because body language does say a lot. And we need to be sure that our body language is very neutral, right? So if that's something everybody, I don't know, maybe everybody in here during your staff meetings talks about it, they call it case conferencing, but sometimes it's good just to do a little check-in and do a little mock session, and kind of you could have fun with it and play with it, but acknowledging that body language is a form of language. And in the work that we do, we want to make sure that we're very neutral in our body language. Continuum of the spectrum. So as you see, Obama, there's levels to this shit, right? There's the spectrum of harm reduction. You have abstinence, who some people will taper off their drug, and their goal is to eventually abstain. And that's great. That's not something that we push. That's something that we supported. We've got people who do drugs for experimental. I was a teenager once. I remember the first time I inhaled weed, and the first time I smoked a cigarette, I wanted to try it, Some of it I stuck with, and then there's a lot of things that I just was like, I tried it. It isn't my thing. I don't like how it makes me feel, and I'm done with it. Then you got people who occasionally do stuff, right? Or what they call weekend warriors. Like, I might drink a little bit, have a little wine every couple of days, or, every couple of weeks go out with my friends and we'll take shots of tequila, our favorite tequila. And, then you've got people who do things casually. And then you got people who are heavy use. Like every day they need to wake up and they need to hit that pipe, or every day they wake up and they put in shots of alcohol in their coffee in order to function. Now, I work at a place where we hire people who use drugs. I don't have a drug tester at the front door. It's about activity and how you are acting at work, your behavior. But some of you might work in institutions where drug use is not allowed to be an employee, and that they will drug test you if they suspect that you are on drugs, right? And so I can't speak nothing to that because at HEPPAC, it's about your behavior. We've worked with people who are methadone users or use heroin, and methadone users looks different than persons who use stimulants like crack or meth, right? Like the folks who we know who, in my experience, have used methadone or opioids will nod out, right? So that's something I need to be a parent of, like, hey, you're nodded at your desk. Do you need to go home? Do you need to go take a walk around the block? You're obviously not going to be driving one of the vehicles during outreach because you're nodding right now. Then I've got other folks who, they're up and they're shoot, 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 shoot back and forth. It's like, whoa, 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 slow down. Do you need to go home? Do you need to take a break? What can we do to support you? Because people who use drugs can work. People who use drugs deserve to have awesome careers, housing, stability, and are actually functioning and giving back to their community. People who use drugs are the folks who have the expertise that we need as providers to deal with people in the population who are using drugs. So if you guys have the capacity within your own settings, hire people who use drugs, give them a chance, but just talk about the behavior, right? Like, we cannot have this specific behavior. It's funny, when I first got in this field, I had a supervisor who smoked big weed before weed was, illegal, before weed was legal, right? And so he said, look, we all about to go blow a blunt at lunch. This is my supervisor at the time. He said, but when we go back to work, don't look high, smell high, or act high, and we're good. Which told me, and he was like, you need to have Visine, you need to make sure you wash your hands, you have a beard, weed, smoke, and smoke stays in your beard, wash your face. People don't need to know all your business, because we don't know who's going to walk through those doors and doesn't understand the harm reduction way things go. I don't know if a politician is going to walk in and see somebody nodded and be like, why do I want to give you money? You got people out here nodded, So it's just about like having those open dialogues with your staff who do use drugs. It's not that you use drugs, because I don't care what you need to do to get up and get here in the morning. But while you're at work, this is the code of conduct. This is what I cannot see. And like I said, this might not even work for some of y'all on here because y'all don't have the same kind of setting that we have at HEPPAC. Let's see. Pre-contemplation. So harm reduction stages. So this is something that we used to use around behavior change, right? Because we know that behavior change is hard. And so we've got contemplation, right? Contemplation is when people are just kind of thinking about it. You've presented them with something and they're contemplating whether this is something that will work for them or if they're even interested in it. And then there is like, even before that, there's pre-contemplation. I'm like oblivious to what you're talking about, never heard of it. And then you present them with something, then it goes into contemplation. Then we start talking about preparation. This is when people start having dialogue within themselves, or they're talking to you as a provider, like, you know what? Let me think about this thing you talked about. Let me think about getting into medication assistance treatment. What would that look like for my life and how I have to function through the day for me to want to get into drug treatment, right? Like, I have to start preparing myself because it's a lifestyle change. If I was used to getting up in the morning, doing a specific drug at a certain amount, and now I'm ready to change for whatever reason, what does that look like for me? Right? What happens when I start going through like withdrawal or detox? How do I check that? Or how do I deal with that? Then there's action, right? You're putting something into action. You have created a plan, and now it's planning your work and working your plan. So it's like, hey, I've decided on this day that I'm going to get into medication assistance treatment. I want them to taper me down off of what I'm currently on as far as the amount of drugs that I take. I don't want to completely stop. I just want to get tapered down a little bit for a month, then taper me down a little bit more. And then it might get to a point where I want to completely like abstain from it. And then there's the maintenance, and whatever that maintenance is for people. This goes to a bigger conversation about recovery, because in some of our worlds where we're sitting, recovery means abstinence, right? But recovery is different for some people. Some people are in recovery, and that doesn't mean that they're abstaining from the drug. It just means that they're keeping steady with their plan around drug use. When I was coming up, recovery meant that you were clean, and they used to call it falling off the wagon, right? Like, oh, I'm in recovery, I can't use drugs, right? But now we're having deeper conversations about what recovery really means for individuals. Someone might still use drugs, but use it in a different way, and they're in recovery from how they used to use it. They've went from their chaotic stage of drug use now to a more maintained level of drug use, and they don't want to ever get back to that chaotic stage of use. So that's recovery for them. And I've been into a whole bunch of back and forth arguments of like, I'm not going to sit here and argue with people about what recovery is. Recovery is individualized. It is subjective. So I would even have those conversations with your participants and your staff that you work with. What does recovery mean for us as an organization, right? Are we encouraging people that recovery for this organization means complete abstinence, or does it mean whatever the participants' end goal is, and we're just going to support them in that? So having this conversation, because all of you come from so many different spectrums and work at these machine hospitals, huge hospitals, right, that kind of have like a clear line of where they stand. And some of y'all might be like the renegade harm reductionist in your program, and you're always pushing up against stuff, and people are like, no, no, no. I'm always like this. You ask somebody 10 times, you might get 9 no's, and on that 10th time, you might get that yes. So if it's something you feel is really important for your program and you feel like it's going to be impactful with your participants, keep asking. You never know. Maybe on the 10th time, they'll be like, okay, we're going to allow you to try this out, right? So just continue up with the courage and the fierceness that it takes to be a harm reductionist, especially in these larger FQHCs who have a lot of red tape, a lot of politics, and they have higher ups who have higher ups who have higher ups who sit at these tables and make decisions when they ain't never stepped a day in your shoes on the field, in the field. Stigma at the medical home. So stigma. A lot of folks have been traumatized from the stigma that they have faced over decades of going to the hospital, right? Some people don't feel special. They don't feel like they get a one-on-one with their doctor. They go in, the doctor's like, okay, what's the problem? 15 minutes of fame, check the box, go, goodbye. At a lot of the non-medical, non-clinical settings, people really relate to that. Excuse me. There was a study that was done in-house of our participants who would go to their medical home less than 1 time a year. This is the place where you're like, okay, Lifelong Medical, or I'm just using that as an example, or Roots or whoever has a medical facility that I go into just for a general checkup. Most folks who are going to their medical home are just going to the emergency room when it gets that bad. But if you have a syringe service program that has an integrated service model, people are coming to that site because there's other stuff that's not necessarily related to medical there. You're getting supplies, you're getting snacks, you're getting incentives for testing. Like a lot of people assume, and it's funny, they're like, I'll be like, who's your doctor? And they're like, oh, HEPPAC, y'all are my doctor. I'm like, HEPPAC is not a medical facility. We partner with medical facilities who come to our sites in non-clinical settings like Roots, Lifelong Medical, and some other agencies, Healthcare for the Homeless, and they provide the medical there. But because it's at the HEPPAC setting with this heart logo right here, some people are like, oh yeah, y'all my doctor. And I'm like, no, we're not your doctor. We're the space where you're actually seeing your doctor, and your doctor is this facility over here. And these folks come once or twice a month. So we have noticed in-house that a lot of folks come to syringe service programs and actually prefer that than going to their medical home. Because they can come one day, see the doctor, check in with them. The next week, they might not need to see their doctor for nothing. Or they can do a brief check-in with them and say, hey, I just got my condoms, I got my sterile syringes, I got some snacks, and I want to tell you how my Hep C treatment is going, right? So we have noticed that with people of color, this has been utilized extremely a lot. We did a sample size of 100. And it was apparent that folks love to utilize integrated service models in non-clinical settings over their medical homes. So harm reduction spectrum, as we've talked about, it is a spectrum. It accepts for better and or worse that licit and illicit drug use is part of our world and chooses to work to minimize the harmful effects rather than ignoring or condemning the drug use, right? Understands that drug use is complex, multifaceted phenomena that encompasses a continuum of behaviors from severe abuse to total abstinence, and acknowledges that some methods of drug use are safer than others. It recognizes that behavior change isn't easy, especially with chaotic drug use. How do you handle the ambivalence of your drug use or setting? So I encourage folks to literally have this conversation with participants the next time you go out and be like, so just how is your drug use going? Like, what's great about it? Always start with the great thing. Like, what's awesome about it? You know, they might be like, well, I'm not in pain. It chills me out. I don't have so much anxiety. And then go into, okay, so what's not so good about it, right? They might, hey, my family treats me a certain kind of way. They think I'm a drug addict. They don't trust me, you know, whatever the case may be, or the drug has actually got me feeling physically messed up. And then talk about like, okay, so what's your plan and how do we help you with whatever that plan is? Utilization in non-clinical settings, as we talked about, using non-traditional medical settings such as like RVs, which HEPPAC, we have this van right here. This is more of like a utility vehicle, but we have a retrofitted RV that has rooms in it where people can come and do abscess wound care, incision and drainage. They can see our medical person who can do Hep C treatment. They can actually prescribe medication assisted treatment in the back. And it's not just about that, but like meeting folks geographically where they're at. Some of our participants don't like leaving a 3-block radius. One is because they're comfortable in that radius. Two is a lot of times they got to watch their shit and they want to be close to it. They're like, hey, in this 3-block radius, I got everything I need. I can panhandle for money. I've got my drugs here. I've got little jobs here. My encampment is here. Everything is right here. And so sometimes it's a lot to ask people to truck across town to get to your services. Fortunately for HEPPAC, we have 3 fixed syringe exchange sites in Oakland and 2 in Contra Costa County, being Richmond and Bay Point, where we're in West Oakland, Central East Oakland, and Deep East Oakland. And all those sites were implemented from the 30 plus years we've been in the game of participants saying, hey, we need something in this area. We need something in this neighborhood. So we have a consistent amount of participants who utilize our services. And usually they're like in back alley, cul-de-sac, very ambivalent settings. So folks aren't on Front Street, right? Because a lot of folks are scared of the police. And we have to have like issues with police showing up. Usually it's the rookie who shows up and then they want to park their car like right in front of the exchange. And so even having the fierceness to go up to a police officer and say, excuse me, Mr. Police Officer, we're sanctioned by the city to be right here. And just you being here, your presence is creating barriers for our participants. And we didn't got into it with the police. They're like, who are you to tell me, like, civilian, like I'm the police, you're trying to tell me to move? I'm not telling you to do anything. I'm just telling you what your presence is doing here. And then a little name dropping always works, right? When you talk about who their boss is and their lieutenants, like, I don't know if you're familiar with, you know, who your boss is, but he's aware that we're here. So can you call him and see what's going on with that? And then usually within 5 minutes, they'll off because, you know, they've called the big guy and the boss and realized, okay, these folks are here. But we even need to have conversation with our participants because police can always be around the corner, right? And get ready to pop our participants for having paraphernalia or whatever the case may be. And there are paraphernalia laws that don't allow them to mess with folks. But if somebody has a warrant or somebody's on parole or somebody has actual drugs on them that are illicit, the police are going to do what the police are going to do. Right? Whether you just came from HEPPAC and you've got a bag full of sterile syringes, safe for smoke materials, well, all that, they might not get you for that, but they might get you for something else. So it's just also having the conversations with our participants, like, how are you protecting yourself from getting hemmed up by the police? Like, what is your method? Like, do you have your drugs in a place where if they search you right now, it's not in your front pocket? You might need to tuck your stuff, right? We have open dialogue with our participants about, like, how are you not getting hemmed up by the police, right? And then normalizing access to medical care in these settings, like just congratulating people, like, who knew what it took for you to come to this syringe exchange in this back alley from wherever you're coming from. Thank you for coming. Thank you for your input. Harm reduction is proven effective. For people who don't get it, just pull the data. It's apparent that harm reduction saves lives. It keeps people alive. It prevents diseases. And these are like the sound bites that we use when people want to totally combat harm reduction and its true impact, right? It's like I'm a broken record. We're doing disease prevention. We're doing disease prevention. We're doing overdose prevention. We're doing overdose prevention. Broken record. It's proven. Harm reduction works. Harm reduction works so well that we used to get funding from the state to do HIV specific testing for people who inject drugs, which is called PWIDs. Back in the old day, it used to be called IDU, injection drug users. And we've done such a good job that people who inject drugs are not at the highest rate of the incidence of HIV, that they don't even give us no more HIV funding no more for HIV testing. Like, we almost put ourselves out of business. this is great because we've diversified our funding. Us not getting this money is not going to close HEPPAC's doors. It was like, wow, we've done so good over the past, 2 decades that they're like, hey, we need to give this money where it is needed most, which is in the MSM, communities of color community, transgender community, and Latinx community. That's where the money needs to go, right? And so even though we see a majority of those folks at HEPPAC, we don't chase money as far as funding is concerned. Our bread and butter is people who inject drugs, people who use drugs, and Black and brown people, right? And so, yeah, it's just interesting. I was like, wow, we didn't put ourselves out of business as it relates to that specific funding when it comes to HIV testing, right? And so we still get hepatitis C funding because we know a lot of people who inject drugs are still at risk for Hep C. But as far as HIV, yeah, we have not got a lot of that funding because it's going primarily to MSMs of color. We use the strengths-based approach, just asking folks like, how are you surviving? What is your method to just staying alive and being able to thrive, right? And it's interesting, we talk to people a lot of times and they're just like, man, I'm just surviving. And we're like, okay, but like, what does a good day for you look like when you're not feeling like you're just surviving, but like you are happy to wake up and like something good happened in your life? And it's sad to say that a lot of folks are literally just out here surviving and they don't have a lot of those stories to tell. So it's like doing the motivational interviewing with people and just like, what's making you smile? If you just smiled one time today, what was the one thing? And like just having them have a space to be able to talk about that. Because sometimes we see people who nobody else wants to see. Or we see people who have been kicked out, burnt a bridge, all of that has happened. And when they come to HEPPAC or they come to your site, you're the only one who might have just asked them how their day was when everybody else turned their nose up at it and was like, oh, get out my face. So just, just like keep that in mind when we're seeing our participants. And then meeting folks where they're at. I'm jumping ahead here. Meeting folks where they're at. Literally geographically and within their drug use. So going to, if you have the capacity to go to certain parts of town where folks are at and to their encampments, go there. I always say go in groups of 3 because this world is real crazy now. We never send anybody out alone. At least groups of 3 because there's that person taking the information, the person distributing the product, and then there's that person who's looking out because we're talking about like a lot of street politics is going on. As you guys are watching the news, a lot of people are dying, getting murdered. Like there's all kinds of crap going on in these streets. I went backwards, sorry. Harm reduction is for Black, Indigenous, people of color. It is how we relate our experiences and choices, action steps to maintain health. For us, by us, not the designer FUBU, if anybody remembers FUBU, but historically the method of which we stayed alive and addressed harm related to being Black and or minority with little to no access to medical care, right? And so historically, Black folks have dealt with oppressed systems in the medical field and every avenue of everything we, politics, medical, education, everything. And that's still happening today. So racial equity looks like making sure Black folk and brown folk have access to equitable medical care. And so we see a lot of folks at our Fruitvale Exchange because that is the Latinx part of town. And even though we have Latinx staff who speak Spanish to monolingual folks, there's still subsets of Latin folk like the MUM community who don't have a lot of services. So we connect with people who are experts in that field, like Street Level Project, who I want to give a big shout out to. They deal with the MUM community. And so it's like, if we're not the experts in something, and we're not planning on being those experts, it doesn't make any sense for us to try to be the experts. It makes sense for us to work with the people who are the experts and do those warm handoff, right? We want to make sure that like, HEPPAC doesn't do housing. I mean, it's something I'm interested in working on, harm reduction housing, but I ain't got no housing units. We don't have no housing vouchers, but I need to know the people who do have those so that when someone has housing at the top of their list, hey, I know somebody over at Abode, or I know somebody over at this other place, and let me connect you with them so we can get you housing, right? So knowing those experts, having your referral book tight and updated for wherever you're at, because those referrals and those relationships with the champions at these places is vital to the success of people utilizing the service. Consistency is key. Showing up, being present, laying it out all on the table, educate, evaluate, and entertain. I like being theatrical. I like for people to smile. I like to acknowledge and enforce people's taking care of themselves. So I'm always like, hey, man, who knows what it took for you to get here, right? Just like being like a good energy when people show up really makes people feel good. Because a lot of times people are going through a lot of depressed shit and they are in depressed states. And when you just smile or just like ask them how their day is and like get them to laugh a little bit, just being humorous, I think that really helps, and it helps build rapport with our participants. It makes them feel good about themselves, which also reinforces their confidence within themselves, because confidence is key, right? And letting people know like you're an expert in your life and you are taking care of yourself just by coming here. Congratulations, right? You came to see me because you know we got something that you want. So here, let me load you down with these supplies and just thank you so much for coming. Uncomfortable conversations. So part of the business is having these uncomfortable conversations. You're going to talk about race, race equity, how to combat racism in everyday life in some of these medical settings. You're going to talk to people who have literally had some racist shit happen to them, and it has gave them a sour taste in their mouth on a specific service. It's like, you know what? They did some racist shit with you over at this provider over here, and I'm sorry that that happened, but let's not make that about you not accessing medical. That just might not be the place for you to get your medical at. So let's talk to you about this other agency over here who might be better in serving you, right? And so having uncomfortable conversations just about drug use, you know, and just about shit that's going on in people's lives that might have really impacted them and had them have like negative experiences that stay with them, and not just stay with them, cause them to inflict harm on themselves, right? And so just acknowledging that you're going to have uncomfortable conversations in this field. It's just part of the business, and embrace that. You can't change people, but you can change your direction, right? And then refer people accordingly to Black drug users health hubs or similar structures. So I had this brainchild when I first became ED, and they had a grant from the California Harm Reduction Initiative. And so they call these homegrown interventions, right? And so I'd had this thing in my mind, and I called it the Black Drug Users Health Hub, AKA BDUB for short. So I was like, you know what? I'm just gonna give it a shot. They said, be creative, I'm gonna do it. I wanted to create a space where Black drug users can talk about the ambivalence of their drug use and the historical trauma as it relates to the war on drugs, and also educate folks about the war on drugs. There's some folks who don't even know that the war on drugs has impacted them historically, right? So it's information sharing, it's education around the war on drugs is how it's impacted them. And then also it's like sharing that expertise, because folks have expertise on their drug use. We hook them up with information on how to access telehealth, which is another alternative for people wanting to go to a brick and mortar or even wanting to come to a syringe exchange. Hey, you got an Obama phone, or you got another way you want to sit in your living room you don't want to do, going to the doctor and all that. Let's talk about telehealth, right? Informing people how they can access telehealth. And so Black Drug Users Health Hub, you come in, we have these open dialogues around the war on drugs, about telehealth, what it's like to be Black in America and a person who uses drugs, how you combat stigma, how you stay alive and stay out of stay out of jail. And then we feed folk, we give them a $50 voucher, they get a cool t-shirt, and then we welcome them to our network. Like, welcome. If you do not have a Black-centered space, then this is your space, right? And you're always welcome to all of our sites and our drop-in center. If you just want to come and talk and have do some crisis intervention or motivational interviewing. So this is not rocket science. You can create a Black drug users health hub within your own setting. It might not be formalized, but you can definitely do that, right? You can make it formal if your entities allow it. Let's see here. Harm reduction saves lives, period, point blank. It is what it is. If you don't agree, just pull the data. And so now, if anybody has Instagram, because just about 2 years ago, I was like, you know what? I want HEPPAC to have an Instagram. So if you have an Instagram, I would love for y'all to hit us up at HEPPAC_Oakland. We do a lot of educational stuff. We have a lot of fun updates and visuals for you. You can check us out. We'll tell you what's going on kind of in the moment if we're at a specific site or got an event going on. And then if you have any questions, you can always hit me up at bcourtney@casasegura.org, which actually now is heppac.org, but this will bounce to the new site. And I just really thank you guys for letting me sit up here and present to y'all, run my mouth getting dry. And now I'm like, I need some water and I want some questions from the crowd. Hit me up, y'all. What you got to ask me?
So Braunz, before folks ask questions, I just want to give you a hand and folks join in giving Braunz a hand. This has been amazing. It has been very informative, and yeah, this has been great. So we definitely look forward to folks asking questions. So if anybody has questions, please, join in right now. I will be manning the chat, so you can come off mic. I mean, you can come on mic or come on screen and ask a question or plop it into chat. So let's have a conversation. Let's have a conversation. What do you all think? Ask some questions. Go ahead. And Braunz, just so what, can you stop sharing your screen so we can just, there we go.
There we go. Right.
So you're getting some love. You're a wonderful presenter and so appreciate your kind and empathetic approach. This was so helpful. We have not set our program up yet. Would love to pick your brain as we get closer. You're amazing, Braunz. We met many years ago and I've always been inspired by the genuine way you approach your work in advocacy. You are a gem. Okay, we know Braunz is amazing.
Thank you.
So other than the wonderful accolades, what questions might you all have? And actually, Braunz, folks are asking if you can plop your contact information in chat too, would be helpful too. And
yeah, I'm gonna plop it in the chat right now.
okay. So Braunz, so maybe to help kind of get the ball rolling, what I heard you mention were a lot of really inventive ways in which you all are thinking about how you do the work and how you engage folks into the services, right? I think one of the things that I really appreciated was you talking about acknowledging that people may not always be okay with asking for free stuff. I loved how you were talking about how is just simply asking someone, how is injecting drugs working for you? Because I think that there's a lot of ways in which sometimes when we do the work, we get focused on doing the work and maybe not focusing on the individual. And you meant something around the strength-based approach. So just folks who don't know what that is, it's a way of looking at people's, not looking at, focusing on people's strengths versus the deficits. We also, the CAPTC does a training on that too, and we can provide some technical assistance. But somebody has a question, it's like, how would you suggest engaging people who are open to SSP services, but hesitant to HIV testing for those who are at a greater risk?
Oh, I love that question. Can you hear me?
Yes, perfectly.
Okay. If you have an integrated service model, which hopefully all of you have or working towards, it means you have a multitude of services at one site. So they may be coming for sterile syringes, and it's like even having an easel board that says free HIV testing, $10 incentive, right? And it's like the little carrot. Sometimes people might not want to access services unless there's a monetary unit. And at the same time, like, it ain't coming out of my pocket. I don't give a damn what you, if this is what got you to take a test to get a $10 voucher, then that's what it is. But also having the open dialogue around like, hey, what are you doing to protect yourself from HIV? And also, what do you know about PrEP and PEP? And then what's your current HIV status? Current, meaning have you been tested recently? Oh, you haven't? Well, we offer the rapid testing. You get your results in 20 minutes. These are your 3 results that you could possibly get: negative, reactive, indeterminate, right? Like just reinforcing and not trying to shove it down people's throats, but just saying, hey, have you ever? What do you think about that? When do you feel like it may be the time? Because some people feel like they don't want to know their HIV status. And then just also reiterating that there's a lot of people who are living healthy ass lives right now who are HIV positive, and they're going to die from something totally not from HIV. They're going to die from walking across the street on Foothill Boulevard because they drive crazy, or they're going to die from something other than HIV, right? There are people living healthy lives with HIV and Hep C, and people who are on treatment are non-detectable and not able to, like 99.9% not able to transmit the disease if they're on treatment. So just having that kind of visual stuff, so people don't always want to ask that. They might just need to see it. So if you're at a site where you have an easel board or a poster, something that has those sound bites around know your current status, get a $10 voucher. It's real easy, takes 20 minutes. We'll hold your hand through the whole process, just anything. Because as Duran was saying, some folks don't want to ask, but maybe on that 5th time they come to that exchange and they see that poster, they might want to do it.
And in Braunz, one of the things that I'm very mindful in listening to how you explain things and how you actually work with clients is very very motivational interviewing kind of modality. It's very strength-based. One of the things that I really appreciate, another strategy that you talked about, was doing like the mock sessions with your colleagues to make sure that what you're saying with your words, one is respectful, and also what you're indicating with your body language. I love the fact that you said that your facial expressions are something that is something that you're working on, and something that kind of says a lot to individuals. So I'm just thinking, when we're talking about how do we create these spaces and these avenues for people to engage in our services, impactfully, especially when we're talking about populations of color. I think you've given some really great strategies, even when you're saying that, people who are experts in their drug addiction and people who have been using drugs in a way longer than you have been alive.
Yeah.
So, and just kind of throwing it out to anyone. So what's something that, a strategy that you've heard, Braunz share during his presentation that might be something that you are considering in the work that you all do? What do you think? Let's have a conversation. Let's talk about it.
Are we waiting for somebody to dial in, or?
No, it's just, I'm just waiting for anybody who feels comfortable
Yeah.
to unmic or to put it in chat. So we do have.
I do love the mock sessions because practice makes perfect, right? And it's okay to make mistakes, right? And so that's the best part about having the mock sessions with your colleagues, about like, okay, I'm going to be this person, this is my role, and you're going to try to sell me on, quote unquote, sell me on getting a test without being too pushy. And then your colleagues around you, like when we were doing like training, like, this is what I think you did great. This is what I feel like you could do better, because ultimately it might not result in the end result of like this person getting a test, but at least they felt comfortable enough. So when it does happen in real life, they're like, hey, I asked them, they still didn't want to do it, and I was okay. And my body language said it's okay. It's like, in the meantime, you don't want to know your status. Okay, it sounds like what you're doing is helpful to you. You're continuing to have one partner. You use condoms. You don't want to know your status. Great. It sounds like you're taking care of yourself. When you're ready, hey, we've got that here.
Hi, can you hear me?
Absolutely. Go ahead, Stephanie.
Hi, I'm Stephanie. I work for an agency. It's called Minority Aid Support Services. And we're getting ready to start doing harm reduction in an area that hadn't been doing it legally. And so we're getting ready to start doing it. And I would just like some suggestions about where starting at 1. What would you suggest?
Starting from like A1.
Starting like A1. Yes.
Okay. One is formulating your plan and your protocols. So this is down to the micro level of how this happens, right? You've got the macro level, which is we're gonna set up an exchange. Okay, that's macro. Where is it gonna be at? What's the time? How many staff is it gonna take? What's gonna be on the line? What's the flow, right? And like, what happens if this happens? So really just, you got to sit down and do those protocols. It's kind of like the non-fun part, but we want everybody to be on the same page. So when people show up, everybody knows, right? Don't look messy, because participants are coming and they're going to be like, well, y'all ain't got your shit together. What's going on here? Like, they going to want to come and get their stuff and go, or they going to want to come and sit there and talk your head off when you like, excuse me, can you step to the side of the line? And what happens when that happens? I need to have somebody go over there like, you know what? I want to continue this conversation, but like, please step to the side. And then you send somebody over there to have that one-on-one intervention with them so that that line can come through. Because, sometimes you get people who are so excited that you are out there. They want to shut the whole line down. It's all about them. They've got open ears. You're like, baby, I want to hear all of that. However, you got 15 people behind you. They get mad. So let me, have this person talk to you on the side. We're going to answer as many questions as we can. But those protocols down to like, what's going to be on this line? We put all our stuff in crates from like, it has condoms, then cookers, then cottons, then this. And this is how many syringes. This is how many smoke kits. This is how many, all of that, right? This is how many candy bars. This is how we even take down the data. HEPPAC just recently went from writing things down to now we have smart devices. Because time is money, right? If I write this down, then I have to get it to my data person, then they have to input it into Access or Excel versus I have an iPad right here, blue, 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 and I just upload the data. So now I don't even have to have a full-time data entry person. I'm doing stuff like in this smart devices, like let's use this technology to work for us even more. Definitely, I see you. And I love those glasses.
Thank you.
Those glasses. Yeah.
Can I have one more question? Can I email you or call you?
Definitely.
Okay. And just one more thing. Would you include the HIV testing, or would you just get the needle exchange part down first and then introduce all the other services?
It depends on what your capacity is. I don't know what your agency structure looks like and how much staff time and FTE you have allocated. I always say start small and you can move into it. But if you like got a whole team and a whole crew, 10 of y'all ready to go, and you got testers and you got, nurses and all that, like just do the protocols and then do a run through. Be like, y'all, this is what it looks like, down to like, let's draw the map of the street and how we park the vehicle and how we pop the tents and how the flow goes. Like, it's got to be like a well-oiled machine. That's the fun thing. I like organizing.
Okay.
It's like, yeah, you gonna do it. And when you do, after we talk, if you want to talk more in detail on another night, I want to see pictures. I might want to I want to FaceTime me when y'all out there. I'll be like, word, get it.
Yeah, you're definitely gonna be hearing from me. Thank you so much. Thank you.
Thank you.
So, I want to be mindful of time. We have about 7 minutes, but Braunz, you have given a lot of ideas and strategies around, changing that inequity to equity in populations of color and creating abilities for folks to access syringe services and harm reduction. And one of the things that I want to do now is I want to ask another poll question. So given the fact that Braunz has shared a lot of different strategies, even the fact of just talking about using smart technologies or devices to capture that information and not having to hire kind of a data intake person, even when he was mentioning the strategy around co-housing medical facilities with HEPPAC, so folks don't have to travel to other locations to seek services and feeling comfortable at HEPPAC and then realizing or having to think that HEPPAC is actually the place where they get that is their actual medical provider, is really kind of thinking of ways in which you kind of address the needs of your targeted population. And that's why I really appreciated when Stephanie was asking the questions, because that's at that beginning stage. It's like, what can we imagine doing to meet the needs of the individuals we're trying to reach? what is existing out there to meet the needs of the folks that we're trying to reach that, you know, may be already done, and partnering with organizations. Braunz is an amazing person to pick his brain, just like Stephanie was doing. So we encourage you. So with that, I want to ask you all, again, you can identify at least 3 harm reduction strategies to ensure equitable access to SSP and other HIV prevention and care services for people who inject drugs. So what you think, based upon all of the wonderful strategies that Braunz has shared with us, so you can name at least 3. I wrote down maybe like 12 or 15 at least, because that's just really engaged. But yeah, so what we're seeing is that, you know, majority of you are in agreement that you got something out of this, which is wonderful and exactly what we wanted to happen. And I also want to encourage you all, take this opportunity to chat with each other. If there's somebody that's here from an organization that you want to either collaborate with or reach out to, send them a direct message. And if there's more information that you all would like, you know, you can definitely email me as well. So with that, I also want to let you all know that this session, if there was anything that you heard in this session, we're going to, it's been recorded, and we'll make it available through our online platforms. It will be on our YouTube channel and also on our website. So you all can go back and listen to aspects of that recording that resonate with you, or, you know, just to hear it again. So we'll send out that information. So want to just make sure that you all are aware that that is coming and you will have access to that. And we're at the end. So riddle me this. You ready? You see that drama, Stephanie? You ready? Okay, Laura and Michael, since you have won the first time, you are out. You are out. So you just sit back. So once again, here we go for a second chance to win a $10 e-gift card from Starbucks. I'm going to ask you a riddle, and the first person able to answer the riddle correctly by writing in chat will win. This one's a little harder, so I'm going to give you 20 seconds on the clock. And remember, if you duplicate the answers, you'll hear this sound. Okay, so here we go. So riddle me this. What is always on its way here, but never arrives? What is always on its way here, but never arrives?
That was fast. Somebody got that.
Okay, and you're right. So Rosalind Penny.
Rosalind was not playing. She knew what was up.
And the answer is tomorrow. Congratulations, Rosalind. Let me make sure I write down your name. Rosalind.
Thank you for that. I'm always thinking about tomorrow, and I need to stay present in today. So.
Well, I am glad that you're
gift card and take a sip for me over at HEPPAC when you get
okay.
Perfect.
And I want to sincerely thank you all on behalf of the CAPTC for spending this time with us on this, our first COP community of practice session. We hope to see you again on our next one, which is November the 9th, which will be presented by the Law Enforcement Assistant Division lead program, and they're out of Seattle, Washington. And they're going to showcase how they've successfully partnered with members of the police force, court system, and others within their community to create a jail diversion program for people who use drugs and are convicted of low-level crimes associated with their drug use. So if you haven't registered already, you still have some time before registration close, and it's going to be another great session. So I am getting you all out on time, a couple minutes earlier, but I just want to say thank you, thank you, thank you, thank you. Have a great rest of your day, and take care.
Y'all have a good one. Thanks, Duran.
Thank you, Braunz. Thank you. Thank you all. Have a
Thank
good
you so
one.
much.